Hello everyone. My name is Dr. Fanula Crowley, and today I'm going to be talking about chemotherapy-related toxicity and oncological complications. I don't have any disclosures, and today we're going to cover a lot, but our main objectives are to describe the most common toxicities of chemotherapy and targeted agents, discuss the management of non-pain cancer-related symptoms, and discuss the management of chemotherapy toxicities. Chemotherapy works by attacking tumors at a cellular level and interrupting processes that are involved in the rapid growth of cancer and tumors. And we give chemotherapy for a number of different reasons. Often we're giving it to cure patients of their cancer, prolong survival, help with symptoms, and often we're giving it to augment the effects of radiation that we're giving concurrently. There are a number of different families of chemotherapies. You don't really need to know what's in each of these families, but I think, really why I wanted to show that we have a lot of different families is often the side effects and toxicities that we see in each of these families is similar for each member of those families. So the toxicity is usually reflected by the mechanism of action of how the particular chemotherapy works. It depends on the drug dosing and the schedule. It depends on the patient themselves, if they have any other comorbidities, and also where their cancer and disease is. It's quite often a class effect for each family, but not always. And usually if we're doing combination chemotherapies, we try and combine chemotherapies that don't have a lot of overlapping toxicity so that it's not too toxic for patients. As I said, chemotherapy works by stopping cells that are rapidly dividing. So when we see side effects, we're seeing those side effects because when we give chemotherapy into the vein or we give it orally as a tablet, it's going all over the body. So not only is it stopping rapidly dividing cells in tumors or in the cancer, it's also stopping rapidly dividing cells or affecting rapidly dividing cells in other areas of the body. So that's why you get side effects like cytopenias, mucositis, diarrhea, nausea, vomiting, and alopecia. So that's kind of your, chemotherapies, which still are the backbone for a lot of our cancer treatments. But nowadays we have more and more targeted treatments that are coming out to treat cancer, and they work a little bit different. Basically, when we're giving targeted treatments, it's usually because that tumor, that cancer is being driven by a sort of mutation in that cancer. And we give these medicines to try and shut down that driver and stop the cancer from growing. The issue is that often these genes that we're trying to downregulate or we're trying to stop or we're trying to target are not just in the tumor. Often they can be on other cells in the body. And as a result, you get a lot of other different side effects like we have here in this diagram. And often we liaise with palliative care to help manage these side effects. We liaise with oncodermatology and cardiologists as well. So we're going to talk now about chemo-induced nausea and vomiting. And to do that, we're going to talk about this case. So we're going to talk about Mr. Jones, who is a 68-year-old man with a new diagnosis of stage 3A adenocarcinoma of the lung, who undergoes a right upper lobe lobectomy. He's receiving adjuvant chemotherapy with cisplatin and pemetrexed. He continues to have nausea and vomiting 7 days after chemotherapy. So this could be the type of patient that you might see in the hospital because this has gone on for 7 days. They haven't been eating, they're dehydrated, they have an AKI, or it's also something that you might see in an outpatient clinic for palliative care if the patient is referred to you by oncology prior to their next cycle. So a few definitions to go through from the beginning. Something that definitely as a resident I wasn't aware of is that actually there are different types of chemo-induced nausea and vomiting. How we treat those different types is different, so it's important to know the definitions. So the first type we have is acute chemo-induced nausea and vomiting. So this usually happens within minutes to hours of getting the drug, and it commonly resolves within 24 hours. It usually peaks at 4 to 6 hours, and we're going to talk a little bit more about the pathophysiology of nausea and vomiting later, but this is usually a peripheral pathway. You're getting signals from the gut that go to the chemo trigger zone in the brainstem, and the receptors mostly involved in this process are 5-HT3. Delayed chemo-induced nausea and vomiting then usually happens after 24 hours after you've gotten the drug, and it may last for up to 6 to 7 days, so it can last for a long time. There are a number of chemotherapies that are more commonly implicated in this process, like cisplatin and carboplatin. This delayed pathway is more common than acute emesis, and this is a central mediated pathway. So usually it occurs because substance P binds to neurokinin 1 receptors in the brainstem. So that's the kind of main process involved in the delayed chemo-induced nausea and vomiting. Anticipatory nausea and vomiting is basically, last time you got the chemotherapy, you had a really tough time with it in terms of your nausea and vomiting. And then when you get to the cancer center, or the night before you go to the cancer center for the next cycle, you're already nauseous, even before you get the drug. And this is a conditioned response, and this process is mediated by the higher cortical structures in the brain. Breakthrough nausea and vomiting occurs if this happens in subsequent cycles, that you've gotten all your, or breakthrough happens if you've gotten your prophylaxis medicine, you've gotten all the medicine to prevent the above types of nausea and vomiting, and you still have it. And then refractory happens, or refractory chemo-induced nausea and vomiting occurs if in subsequent cycles, even though you've gotten all your prophylaxis medicines, you still end up having nausea and vomiting. So those are your different types. The next question then is, who's most likely to get chemo-induced nausea and vomiting? And the strongest factor is the emetogenic potential of the agent that you're giving. And we're going to talk a little bit about how you figure that out later on. But that's the biggest risk factor for who's going to get nausea and vomiting. Other risk factors include if you've had chemo-induced nausea and vomiting previous, if you're young, if you're female, if you've little or no history of alcohol use, if you've anxiety, if you are going into this thinking you're already going to have a lot of nausea, if you have a history of motion sickness, or if you have a history of morning sickness during a pregnancy. But as I said, the biggest risk factor, or the biggest predictor of you having chemo-induced nausea and vomiting, is the type of medicine you're getting and what is the risk of nausea and vomiting with that medicine. And basically what we do is we divide medicines into 4 different categories based on their emetogenic risk. So if it's a drug that has a high emetogenic risk, it means that if I was to give that drug to 10 patients, 9 of those patients are going to have chemo-induced nausea and vomiting. In the moderate category, 3 to 9 of those 10 patients would have chemo-induced nausea and vomiting. And for low and minimal, the rates are obviously much lower. And I know you're saying, I'm a palliative care doctor, how am I supposed to figure out what regimen this patient is getting and what category that regimen goes into? And how you figure that out is from the NCCN guidelines. So there's a whole guideline on managing chemo-induced nausea and vomiting. And they update this guideline very often. But basically what they do is they put each chemotherapy agent into one of these categories of high, moderate, low, and minimal. A few things to note, though. One thing is that the dose of the medicine matters. So I'll give an example of carboplatin, which this patient, the case we're doing now, the patient is getting. So carboplatin, if you're giving an AUC under 4, that's not highly emetogenic, but if you are giving an AUC greater than 4, which is a higher dose, then it is in the high emetic risk category. So the dose that you're giving matters for a lot of these agents. The other thing is that if you're giving a combination chemotherapy, so if you are giving a regimen that has a number of different drugs, basically how you figure out what category that combination regimen goes into is based on the agent that has the highest emetic risk. So if you have 3 agents that are in the moderate category and you have 1 in the higher category, you're still going to give the treatment for as if all of them were in the high emetic category. So that's kind of an important differentiation. In general, if you're doing board questions, patients that are getting cancer treatment for breast cancer and leukemia, these drugs are pretty much all in the high emetic risk category. There are a number of targeted agents, as you can see, also in that high category. But in general, often in these questions, it's going to be someone getting leukemia or breast cancer treatment. You can see then there are a number of different medicines for your moderate emetic risk. And then you can see there are even further ones for your low emetic risk or your minimal emetic risk. And as I said, this is updated very frequently as new drugs are being approved. So what then about radiation? Because often we're combining radiation with chemotherapy. And you can see that each type of radiation also has an emetic risk associated with it. If you're combining it with chemotherapy, again, it's the same as your combination regimens. The I guess category for the whole combination of radiation and chemo depends on what has the highest or what the highest level of emetic risk is for any component of that regimen. So if someone's getting total body radiation, but they're getting moderate emetic chemotherapy, you're still going to give them the regimen as if everything in that regimen has a high emetic risk. Why is it important to be quite aggressive in treating patients for and preventing chemo-induced nausea and vomiting? It's because we know that if you get the regimen right, day one, cycle one of the first day of chemo, and you prevent the acute chemo-induced nausea and vomiting, the patient is less likely then to get the delayed chemo-induced nausea and vomiting. If you treat and prophylax appropriately to prevent delayed chemo-induced nausea and vomiting, they are less likely then to have chemo-induced nausea and vomiting for the next cycle, or they're less likely to get anticipatory nausea for the next cycle. So it's really, really important to get this right in the earlier cycles, because it means that you're hopefully not going to run into trouble with chemo-induced nausea and vomiting that's refractory in later cycles. So then we get to how do we treat chemo-induced nausea and vomiting? How do we prevent it? And to understand how we do that, we kind of have to go back to pathophysiology and figure out what's actually involved in the process of vomiting. So as you can see from this diagram, there's a lot of different processes involved. But in general, you have in the brainstem, you have this vomiting center, and the vomiting center is taking inputs or afferent information from a lot of different areas in the body. So it's taking information or receiving information from your GI tract, from your heart, from the inner ear, from the higher cortical structures, and also from the chemoreceptor trigger zone, which is also located in the brainstem. It's taking in all of this information, and then depending on what's going on, if the decision or the threshold is met for the patient to vomit, then you have efferent limbs coming out of the vomiting center that make us gag or make us do the vomiting reflex. And you can see in all of these processes, there are a number of different receptors involved. The main ones you have in the inner ear, you have the histamine receptors, you have the muscarinic, which is an acetylcholine receptor. In the chemoreceptor trigger zone, you have dopamine, you have neurokinin-1, you have 5-HT3. And in the vomiting center, you have, again, histamine, muscarinic, neurokinin-1, and 5-HT3 as well. So when we think of treating and preventing chemo-induced nausea and vomiting, these are the receptors that we are trying to target. And this is a really nice diagram, which I really like, which gives you an idea of where these targets are most involved in this process. So you can see that your 5-HT3s are really involved earlier in this kind of acute chemo-induced nausea and vomiting, where you can see that neurokinin-1 is very much involved in the later delayed chemo-induced nausea and vomiting. You can see steroids can be used really for acute and delayed, because they have a wide breadth of action here. So this is a really good diagram when you're thinking of how to treat and prevent chemo-induced nausea and vomiting. So I spoke that there is a number of different receptors involved in kind of general nausea and vomiting. In chemo-induced nausea and vomiting, the main ones really that we're targeting are dopamine, serotonin, and substance P, neurokinin-1 receptors. So the highest therapeutic antiemetic agents, so your 5-HT3 serotonin receptor agonists, these are your odancetrons, your palacetrons. Corticosteroids, it's dexamethasone really is the one that we use for this purpose. We don't really use the other ones in this setting. Your neurokinin-1 receptor antagonists, then your aprepitant and your fosaprepitant, and then olanzapine, which is a 5-HT2 and a D2 antagonist. The ones on the bottom, the lower therapeutic index antiemetic agents, are ones that really have kind of fallen out of favor. Your main ones are going to be the four at the top. So starting with dexamethasone. So we don't really know how dexamethasone works in this setting. It's not like it targets a specific receptor like the other agents, but we do know it's very efficacious. It's also pretty cheap and can be used in the acute and the delayed phase. The only thing with this is obviously steroids are a little bit tricky in certain populations of patients, especially patients who have uncontrolled diabetes, uncontrolled hypertension. And I have had scenarios where we have to get endocrinology on board to manage glucose around the days of chemotherapy because of this. Your 5-HT3 antagonists, then you have first generation, you have second generation. The first generation all cause QTc prolongation. So I think ondansetron is really the one that we use most commonly in both the inpatient and the outpatient setting. It does come in an ODT formulation, which goes under the tongue, which is pretty helpful. And then second generation, we have palazestrant. And palazestrant has a 40-hour half-life, so it lasts much longer than your ondansetron, which has to be really dosed every 8 hours. And the second generations are not QTc prolonging, which is also important. The second generations in general, I know in our institution, you're not allowed to give them inpatient because they're too expensive. So we do give them outpatient. Sometimes people will ask, what is better to give the long acting versus giving the short acting? And for acute chemo-induced nausea and vomiting, they're pretty much the same in terms of efficacy. But obviously, it's a lot more labor intensive to be redosing something every 8 hours. So for delayed phase nausea, vomiting, the palazestrant is obviously better. So then your NK1 receptor blockade. So I think these are the agents that if you came from residency or you did another fellowship, these are the ones that you probably didn't use as much. But as I said, basically you have a high density of substance P neurokinin receptors located in the brain regions that are implicated in the emetic reflex. And these are active in the acute and the delayed phase, but as we saw in the previous diagram, NK1 is very much involved in the delayed phase chemo-induced nausea and vomiting. The two agents that are approved in the US are arpepadent, which is an oral agent, and fosaprepitant, which is IV. There's no significant difference in efficacy between those two. And these really augment the effect of steroids and your 5-HT3 receptor antagonists. So that's, I suppose, what we're trying to target. Those are the drugs that we have available. How do we then give them to our patients? So it's kind of split into two. You have the regimen that you give the patient on the first day of cycle when they come into the cancer center, and then you send them home with medicines for the next few days to prevent the delayed. So to prevent acute nausea and vomiting, there's a few different regimens here. This is from the NCCN guidelines again. I would say in our institution, what people that are getting a high emetic risk regimen get is they will get palazestrant 0.25 once. They will get dexamethasone 12 milligrams. They will get fosaprepitant 150 IV once, and they will get olanzapine 5 milligrams once. So that's what they get if they're getting a high emetogenic treatment. They'll get that when they come in to get their treatment on the first day of the cycle. Then we send them home with olanzapine 5 milligrams that they take every night for days 2, 3, and 4 of the cycle. And we also give them dexamethasone 8 milligrams to take on days 2, 3, and 4. It's written here, as you can see, in treatment option A for days 2, 3, and 4 that you can do aprepipadant as well, which is your NK1 receptor antagonist. We don't do that at our institution, but that is also an option. And you can see in the NCCN guidelines, they give different options for both day 1 of the cycle and days 2, 3, and 4. After day 4, if the patient is still having nausea or you stop the medicine and they develop nausea, you can prolong these regimens for another number of days. And then often patients, don't need them again until they come back for the next cycle, which depending on what they're getting, could be in 2 weeks, could be in 3 weeks, could be the following week. These are the suggested regimens to treat and prevent nausea for moderate emetic anti-cancer agents. You can see that the regimens that we have here are just not as intensive as the ones we have for high emetogenic risk treatments. So no NK1 receptor for your kind of main main option here on the top, and you can see in the days after, sometimes you might give steroids, or sometimes we might just give 5-HT3 monotherapy, depending on what they got on day 1. So it's not as intensive. And then low emetic risk, often we'll be able to just do PRN for these patients, or we can start doing scheduled and then taper it off, depending on how they're doing. So oral agents. So as I said, with these chemotherapies, often you're coming in, you're getting the medicine, and then you're not coming back for 2 to 3 weeks. But oral agents are medicines that you take every day, and often you're taking them every day, for many, many years. So if you're having nausea, it can be pretty debilitating if you're having nausea every day. And for these oral agents, they are also put into categories based on their emetic risk. I think one of the ones to highlight here, especially that's in the moderate to high risk category, is temozolomide, which we give with radiation for patients that have glioblastoma multiforme. And this radiation and chemo, or temozolomide, goes on for a number of weeks. So for these patients, what we usually do is we will start the ondansetron the night before they get the treatment, and then every day they take the ondansetron before they get the temozolomide. And in general, that's the approach that we would take for patients that are taking tablets every day that have a moderate to high emetic risk. And then for lower emetic risk, again, we can think about doing as needed, or escalating to scheduled if as needed is not helpful. So then what if you have done everything? What if you have, given the medicine to prevent or treat the acute nausea and vomiting? They've taken their medicine for the next few days. What then? And I think the first question is always to check that they did get what they should have gotten for the treatment that they're getting, because often what I find is I'm on call at the weekend and I get called about someone who has nausea and vomiting, and then I go to look at the treatment plan, and the oncologist has taken out, for some reason, a component of the prophylaxis anti-nausea medicines. And the second question then is ask the patient, were they taking the medicines for the days afterwards? I think often prior to the first cycle, we're very proactive in telling patients that they need to take this medicine. In subsequent cycles, they might have ran out of the medicines, they might have forgotten why they were needed, and they might not have been taking them. So they're important questions. But if they have been taking the medicine as prescribed, and they did get all of the components that they should have gotten, then what do you do, and how do you treat this? So the first thing is to make sure that you have all of those receptors covered, that you're targeting each of those receptors that we spoke about earlier on. If you're not, then make sure that you add on some coverage. The other thing is that if you have agents that are PRN, as I said, you would escalate and make them then scheduled. If it's still uncontrolled, I think you always need to kind of think of, are other things going on? Could they maybe have brain mets? Could they have Addison's disease or low cortisol if they've gotten immunotherapy in the past? Do they have H. pylori? I've been caught out once with a patient who had really difficult to control nausea and vomiting. It was H. pylori. Do they have gastritis? Do they need a PPI? So it's just making sure that there's nothing else going on. If there isn't anything else going on, I think in general, our preferred agent for breakthrough chemo-induced nausea and vomiting is olanzapine. If they're already getting a low dose of olanzapine, you can increase it. It just has to be given at nighttime because of the increased risk of sedation. Benzodiazepines are also an option, but obviously not suitable for elderly patients or certain populations of patients. 5-HT3 antagonists, steroids. And you can, as I said earlier, you can, if it's ongoing for a number of days after you stop the prophylaxis, you can just extend the steroids and the olanzapine for that time. This is a study that was done back in 2013, comparing olanzapine with Reglan or metoclopramide for breakthrough nausea and vomiting. Olanzapine won this out. I think in general it's won out in any study that has been done looking at breakthrough nausea and many systematic reviews and meta-analysis. So because of that, MASC, ESMO, and ASCA recommend olanzapine for breakthrough nausea and vomiting. NCCN have it as a preferred regimen. I'm going to run through these slides pretty quickly, but you can see that there are also other medicines that can be used to target or to target the dopamine pathway. Compazine we still occasionally use, although I think is less favorable now that we have studies that show that olanzapine is more effective. Tygan is one that we use in patients who have prolonged QTC. Although olanzapine, in low doses doesn't really prolong the QTC, but if someone had a crazy prolonged QTC, sometimes we use Tygan, although it's not very effective. And then metoclopramide, Reglan, I think in general, we would only use it if we think there's a component of gastroparesis or something else that might be contributing to somebody's nausea. Histamine antagonists, I've written here, but in general, we don't really use these in chemo-induced nausea and vomiting unless we felt someone had like vertigo or something like that else going on. The acetylcholine receptor antagonists, I think, have most use if we think there's nausea ongoing because of maybe a partial bowel obstruction or decreased peristalsis. These have a lot of off-target side effects like dry mouth, constipation, etc. But scopolamine and glycopyrrolate are two options in this class. Dexamethasone and lorazepam we kind of spoke about. We'll talk about anticipatory nausea in the next slide. Octreotide generally we use again in more an obstructive situation. Metoclopramide, as I said, really only if you think someone has gastroparesis. Your antacids, your PPIs are good adjuvant agents if you think that there's something like that going on. Cytoprotective agents then like sucralfate, especially in someone that's getting radiation, you think there might be some esophagitis or something like that contributing to the nausea, that can sometimes be effective. And behavioral techniques we'll talk a little bit about in the next slides. So this anticipatory nausea, this is, I said, that you've had a really terrible time with the chemotherapy previously, and now the night before you get the chemo or the morning of, you're nauseous even before you get it. And this can be really, really challenging. And again, this kind of reinforces the need to be quite aggressive and on top of nausea in earlier cycles to prevent this from happening. Really the only kind of medical treatment that has proven to be effective is lorazepam, but again, lorazepam is not a medicine that we can give to all our patients because of the various side effects and the sedation and the propensity for addiction. So there are also a lot of other non-medication techniques that are listed here. I would say that sometimes it's very challenging though, because a lot of these are not things that are, say, covered by insurance, and it can be quite challenging. But these are all options for that situation. Okay, so I know that was a very quick run through of something that is a little bit complicated in ways, but that is chemo-induced nausea and vomiting. Now we're going to move on to chemo-induced peripheral neuropathy. So here we have a 55-year-old woman who has completed chemotherapy with docetaxel, carboplatin, and trastuzumab for stage 2B breast cancer. It is 1 month post-chemotherapy completion, and she reports burning sensation in her hands and occasional difficulty using zippers. So chemo-induced peripheral neuropathy, it's most common with certain families of chemotherapies. As I said earlier, often you see certain toxicities more commonly with certain families. There's a number of different chemotherapies that can cause it. And, unfortunately, once it happens, it can take up to a year to improve. And for some patients, it won't improve. Important, though, when someone comes to you and they're having, neuropathic pain, that you take a really good history and try and figure out, is this chemo-induced peripheral neuropathy, which has one treatment, or is it a tumor compressing on a nerve that might have another treatment? Because often it's not the medicine itself is causing neuropathic pain. It also might be the cancer. So signs and symptoms depend on the length of infusion, the dose, comorbidities. If you have a patient that already has mild peripheral neuropathy from diabetes, often if we give chemotherapy that causes neuropathy, that's going to get much worse. And the symptoms are divided into sensory, motor, and autonomic. So your sensory symptoms, this can be really a wide variety. Often patients will come in and they'll say, my hands feel like, they're not really waking up in the morning. They feel like they're more dead. Or someone will say, I got to grab something and it's like my hand is going to fall off, like it's burning. So there are a lot of different symptoms that patients can have other than numbness and tingling. Obviously, neuropathic pain generally is burning, electric shock, feeling like your hands and feet are on fire. Motor symptoms then, weakness, gait disturbance, balance disturbance, difficulty with fine motor skills like buttoning or clothing, sewing. And often, these will come after the sensory symptoms. So that's why it's really important for us in the oncology clinic to really be asking about sensory symptoms every visit. Autonomic symptoms also include constipation, urinary retention, sexual dysfunction, and blood pressure changes. So how do we figure out how bad this is? And sometimes it's not easy because, again, I think it's sometimes very hard for patients to describe exactly what they're experiencing. But in general, I try and figure out, is it affecting their ADLs? If it is affecting ADLs, and that's a grade 2 chemo-induced peripheral neuropathy. And just to add why that's important is if someone is having a grade 2 toxicity, this will often mean we'll have to stop or reduce the treatment. So how do we treat chemo-induced peripheral neuropathy? This can sometimes be a little bit of a complex question because often, if someone comes in and they have advanced cancer and they're having severe neuropathic pain, it's appropriate in that scenario to give opioids as first line because opioids will kick in quicker than any of our adjuvant medicines. It sometimes gets a little bit tricky for patients, though, who are in remission or who have had curative intent treatment and they have, bad peripheral neuropathy, because in those cases, they're not usually patients that we would be giving opioids to, and that can often be quite challenging. But if opioids are appropriate, depending on the clinical context, that would be first line for most patients with moderate to severe neuropathic pain because it acts quicker. There are several then adjuvant agents that are helpful. For chemo-induced peripheral neuropathy, duloxetine is your agent of choice. Some things to remember with the duloxetine, unfortunately, it can cause some GI upset and it can also cause headaches, which is kind of a little bit of a random one that I've been surprised about. It also can't be, stopped abruptly. And usually you have to start at, 30 milligrams and then increase to 60 milligrams after a week if they're tolerating it. But for chemo-induced nausea or chemo-induced peripheral neuropathy, that is the agent of choice. We're going to go through the trial in the next slide. Pregabalin is the agent of choice for general cancer neuropathic pain. I think the issue often is, though, that insurance companies won't cover pregabalin unless someone has had a trial of gabapentin. So that is sometimes challenging. There are topical agents as well that aren't as effective, but I have them listed there. So this is duloxetine. This is an RCT that was done a few years ago, looking at patients who had gotten taxane and oxaliplatin, which are two drugs that cause peripheral neuropathy. And what they found is that there was a decrease in pain after the 4 weeks. 59% versus 38% reported decreased pain. All of these agents are effective in patients that have pain as a result of their peripheral neuropathy. They're not as effective in patients who do not have pain and have more numbness and tingling. In those cases, it's hard to treat the kind of discomfort associated with going around with numb fingers and toes if there's no pain component associated with it. Then talking about pregabalin. So this was a study that was done again a number of years ago, comparing amitriptyline, gabapentin, pregabalin, and placebo. Duloxetine was not included in this, but you can see pregabalin is the third group, and you can see in the fourth visit there was a reduction in cancer-related neuropathic pain in that group compared to the other groups. The mean change here was 5.3 compared to the others, so it would suggest that it's more effective in a kind of general cancer neuropathic pain where you cancer pressing on a tumor or invading into a nerve. That pregabalin is probably the agent of choice in that case. As I said, duloxetine was not included in this. So your TCAs, your nortriptyline, your amitriptyline, have not been shown to really be effective, and they do have a lot of side effects. Your glutamine and your alpha lipoic acid have been, studied in trials, but are not really guideline recommended. Then your non-pharmacological components. So I've listed a number of interventions here. I think scrambler therapy, which is the last one, is the kind of new kid on the block. But, it's very difficult to do kind of large scale trials for these type of therapies. And it's also in clinic, it's very difficult to get these covered by insurance a lot of the time for patients. So these also are not, guideline recommended as the agents of choice. So that's chemo-induced peripheral neuropathy, cancer-induced neuropathy. So duloxetine really is your agent of choice for chemo-induced, pregabalin for kind of general cancer and neuropathic pain. But we spoke about kind of the various limitations of them. Okay, so now we get to the last topic that we're going to cover, and this is cancer-related anorexia and cachexia. So here we have another case. So Mrs. Jackson has stage 4 lung cancer, recently progressed on second-line immunotherapy with pembrolizumab, and on admission, her daughter tells you that her mother is not eating well and has lost about 15 pounds in the last month. The daughter is extremely concerned and would like treatment. So this is a complicated topic. It's not, I think when I was a resident, I thought that this was fairly clear cut. You don't want to, you're not eating enough, and then the cancer is taking energy. But there's a lot more really involved in it. In general, you have a lot of processes in the body that are involved in giving you an appetite. And when you have cancer, a lot of those processes get dysregulated. The tumors send out these cytokines telling you not to eat. Your mood might be lower, you might be in pain, you might be less active, you might have a lot of symptoms from the chemotherapy you're getting or from the cancer. And all of these things tell your body that, you don't want or need food. So it's a failure of our usual appetite signals. And this is very, very common in patients that have cancer and has a profound psychosocial impact as well. Cachexia then is a little bit different to anorexia because cachexia is basically this hypercatabolic state, which is defined not only by weight loss, but also accelerated loss of skeletal muscle and this chronic inflammatory response or this chronic inflammatory syndrome. It can affect up to 50% of patients with advanced cancer. But in this case, it's not just the fact you're not meeting your calorie needs. It's a little bit more than that because you also have this hypercatabolic state. So even if you had a patient who has cachexia or cancer-related cachexia and you give them all the calories they need, often it's still not going to mean they're going to put on muscle mass because of this this syndrome that they have, where they have this hypercatabolic state and chronic inflammatory syndrome. It's also important to differentiate that, often we will have patients that come, they have cancer-related cachexia. We treat their cancer with chemotherapy or immunotherapy or targeted therapies, and the cancer shrinks and the cachexia will get better. But then you also have general anorexia cachexia at the end of life. So you have someone who's gone through a number of different rounds of treatment, like this patient that we're talking about. And in this case, this is likely not something that's going to get better. And, the approach and the education that patients need in this setting is a little bit different. So the first thing, if you have a patient who has cancer that's coming and they're losing weight, losing muscle mass or not eating, the first thing to do and the most important thing to do is to take a history. So you want to know what else is going on, what other symptoms they have. Are they having issues with swallowing? Are they having pain with swallowing? Are they on medications that make them lose weight? Oncologists often will start people on Ritalin, which makes them lose weight. Other things which I nowadays make sure to ask for, but for many years didn't really consider them as major things, is, are there other barriers to getting food? So I'll give an example. Last week, I met a patient losing weight. And when we got down to the nuts and bolts of it, she was coming every day for radiation to the hospital. And really the food in the hospital, it was too expensive for her to buy when she was here. And she didn't know really what food she could bring with her that would last the whole day while she was at radiation. So food insecurity and those practical challenges, issues with feeding, they also need to be screened for. So when you do that history, you kind of identify the other things that are going on and you try and manage those. You also, in the setting of a patient nearing the end of their life, you need to do a lot of education with family members and the patient that, this unfortunately is kind of a natural process. And think of different ways to make the patient and family members feel empowered in this situation, and things that they can do to make the patient, I guess, feel better, giving them their foods that they like to taste, but not forcing them if they're not, if they don't want to eat it, etc., etc. Making sure that you're including their favorite foods, nutritional supplements that they like. Our nutritionists often are very, very helpful in this setting in terms of prescribing nutritional supplements to help patients. These patients often will not be able to sit down and eat a steak. So often I tell them that it's small and frequent meals throughout the day, and grazing on high calorie foods and high protein foods. If you've done all that and you want to try a medicine to help with appetite, I think this is, certainly, depending on a patient's goals, is appropriate. And then the question becomes, what medicines would you use? And in general, for many years, this was not a great space. We didn't have a lot of great options. So megestryl acetate is one medicine that was used for many years, does improve appetite, made patients put on weight, but it caused clots, it caused swelling, and there were actually some studies that suggested that actually might increase mortality. So in general, we don't really use this much anymore. Steroids can be effective in someone who has a limited prognosis, or if you're going to use them in the short term. But obviously we know if you give steroids long term, they have a lot of side effects that often can cause, delirium, and other issues as well. So, in general, they're only kind of a short-term solution, and often in people that have a limited prognosis. Mirtazapine was kind of all the rage for many years, but we had a recent RCT that showed that really it's not effective any better than placebo in this setting. So in general, I think in my practice I would use it if I have a patient who maybe has a little bit of a mood disorder, isn't sleeping. In general, if someone is, moderate depression or higher, then you want to do a more effective SRI, not your mirtazapine. But for general anorexia, cachexia, not very helpful. And then you have your dronabinol and your cannabis products. Dronabinol is really only shown to be effective in patients with HIV and cachexia, not in the cancer space generally, in kind of bigger or more substantial studies. Cannabis, again, has not been shown to really be effective, although I have patients that anecdotally think it is effective for them. But again, we don't have great evidence to support cannabis in this setting. So this was kind of the landscape for many years. And then a few years ago, we had this study which looked at the use of olanzapine, 2.5 milligrams, for patients getting treatment and had chemotherapy-related anorexia. So important that, again, this is a different population of cancer patients than a patient that's nearing the end of their life and has anorexia and cachexia as a result of that. So those were not patients that were included in this study. So in these patients that had cancer, were getting treatment, you can see that more patients gained greater than 5% weight from baseline in the olanzapine versus the placebo group. It was 60 versus 9%. And less patients lost weight in the olanzapine group. Was 14% lost weight versus 59% in the placebo group. So because of that, ASCO did change their guidelines last year, and they recommend that for patients with advanced cancer, that you can offer a low dose of olanzapine once daily to improve weight and appetite. And I have found this to be effective in my practice. You can see recommendation 2 also says that you can do a short-term trial of a progesterone analog or corticosteroid in patients experiencing weight or appetite loss as well. But I think a lot of this, there needs to be kind of education about the expectations and the risk benefits in this situation. So we'll finish on a question, a board question. So we have a patient who's receiving a highly emetogenic chemotherapy regimen and received the standard of care for prophylaxis, fosaprepidan, palazestrant, dexamethasone, olanzapine. It is now day 9 after chemo and he is still having nausea and emesis despite using compazine. All the following should be considered for the first-line treatment options except. And you can see you have the options. So the answer here is ondansetron, because as we've learned, that's the most effective in the acute setting and not as effective in the delayed nausea and vomiting setting. So good luck in your boards and thank you for listening.